So I'm going to go ahead and start um, with my subject of discussion today, and that is on improving fertility outcomes in female genital tuberculosis. Every single subject regarding female infertility or endoscopic surgery, somewhere the subject of female genital tuberculosis will come up if that talk is happening in India. Because we know that some problems are so complex that you have to be highly intelligent and well-informed just to be undecided about them. Really, there are no 100% answers in this complex problem. And so I'll just take you through what are the current opinions on the management of this subject. We know that female genital tuberculosis is hugely prevalent depending on which part of the world you're looking in. It may be as low as 1% in the US to 1 to 19% in various parts of India. And especially in people who are coming for infertility treatment, IVF, the incidence is huge. It could be 25% overall or almost 50% in tubal factor infertility. Investigations, many of them haven't really changed over the years from your basic ESR, X-rays, Mantoux. Endometrial biopsy still plays an important role with the smear and culture. PCR became very popular, and then we realized that there were so many false positives. So again, there's a bit of an issue with them. Gene expert is becoming popular. HSG has been there for years and still has a role to play. Ultrasound also in certain cases with tubo-ovarian masses, etc., may have a role to play. And of course, endoscopy, which I really think is becoming an extremely important diagnostic test, particularly endometrial tuberculosis. I think imaging doesn't play that important a role. But when you put in a hysteroscope and you see the typical features of adhesions or thin endometrium, pale endometrium, you will very strongly suspect tuberculosis. Also HSG, obviously if you see the images shown below, the typical features, multiple tubal occlusions, beaded appearance, hydrosalpinx, classic of tuberculosis, particularly in our country. And if a biopsy seconds that confirms the diagnosis, then you're pretty sure it is tuberculosis. We all know if you put in a laparoscope and you see a picture similar to what you're seeing on your video now, or if you see this inflamed uterus, salpingitis, TO masses, partial tubal occlusion, maybe dye dripping out bit by bit with, adhesions in the periphery, free peritoneal fluid looking like, blood-tinged serous fluid, caseation actually, or a very frozen pelvis adhesions. I think this is very, very classic of tuberculosis. And we already spoke about hysteroscopic picture, so there can't be any other diagnosis in situations such as these. So very many times when nothing else tells us, laparoscopy and hysteroscopy will give you a conclusive diagnosis. Once you have this diagnosis and the disease is acute, obviously we go ahead and treat. Most of us are familiar with the DOTS, the directly observed treatment short course, where we give 4 drugs for 2 months and 2 drugs for 4 months. And typically the drugs are INH, rifampicin, ethambutol, and pyrazinamide. So that is standardized. Very often we take our physician friends with us when we're treating the patients. What about surgery? Is there really a role for surgery in female genital tuberculosis? Very rarely. Surgery is usually avoided unless it's something like drainage from a tubo-ovarian abscess, a pyosalpinx, etc. Or sometimes when there's an obstruction and you have to go inside and release that, an intestinal obstruction. But we do know that when you put in a laparoscope in patients who are badly affected by tuberculosis, there can be a lot of complications because of non-availability of surgical planes, injury to bowel, hemorrhages, etc. But despite that, sometimes you have to go in, you may have to remove the tubes if there's bad hydrosalpinx, you may have to clip the tubes, etc. One thing you don't do is try to do a tuboplasty, because in these cases, there may be a flare-up of tuberculosis or a very high risk of ectopic pregnancy too in these patients. So patients such as these, which you see on your screen today, very, very difficult to treat because of the pathology that has caused this particular appearance. So the question in tuberculosis always is latent tuberculosis. Do we treat it? And many, many Indian studies, essentially Indian studies over the years have told us that if you pick up latent genital tuberculosis very, very early, only PCR is positive, no other obvious evidence of tuberculosis. If you treat them, maybe you'll be able to control the disease, maybe you'll prevent it from damaging. But it is very, very controversial because you'll end up treating too many patients, and that will have its own set of complications. In fact, there's a nice study from Dr. Kriplani where she took 100 patients, did a endometrial aspirate DNA PCR. The positive patients, half of them received antituberculous treatment, half of them she did not treat because they were only PCR positive, nothing else. And it was found later on that the pregnancy rates, whether you treated these patients or didn't treat them, was the same. Even if you gave them treatment with full treatment, 6 months of antituberculous therapy, and you tested them again with the DNA PCR after a year, they were still positive. So basically, treating these just PCR positive patients is highly debatable. So many challenges we encounter when we're trying to treat these patients, even with IVF. So what happens, the main issues that we encounter in doing fertility treatment for these patients is that there is poor endometrial blood flow, ovarian reserve is low, and there's already a lot of damage that has happened. And so even IVF is often not successful. One of the major problems we encounter is poor ovarian reserve, because this tuberculosis has affected the ovaries and damaged them, even though you may not obviously see any big lesions. And this nice study by Jirke just 2 years ago has said that these patients definitely have a lower anti-Mullerian hormone, antral follicle count, and though eventually with IVF their pregnancies may be achieved, it takes much longer because of the poor ovarian reserve. So be conscious of that. The moment you see a young girl with poor ovarian reserve, think about tuberculosis. What if you diagnose them early and treat them with antituberculous therapy? Again, J.P. Sharma's study a few years ago has said that there is an improvement in AMH and AFC. So if you pick up the disease early, definitely treat them and then go ahead and do the ovarian stimulation. You'll find slightly better outcomes. What about the endometrium? So ovary, we have already seen the effects. Endometrium, we know that the thickness is extremely important. The thickness, the pattern, the endometrial blood flow, all very important for implantation and pregnancy. And in tuberculosis, this endometrium is very badly affected, poor vascularity, adhesions, thinness of the endometrium, etc. And so because of these problems, even when you do IVF, the results are not that great. We've already talked about poor responders, high dose of gonadotropins, poor endometrial receptivity, and the egg and embryo quality being poor. But that is the only option that they have. Nothing else works in these particular patients. So eventually we have to go to IVF, and very recent, just this year, the European Society guidelines have come out for these patients who are very poor responders that use GnRH antagonist or agonist, do 300 units of gonadotropins. More than that doesn't really help. And you can combine them with clomiphene if need be. So good stimulation is very, very important. And with all your efforts, eventually the success rate of IVF could be anywhere between 10%, 6%, 8%, and very few studies giving even 30% success rate. But when we go into those studies, it is shown that it is not only IVF, but even in patients who are very bad, even surrogacy and adoption have been included. And that's how their eventual outcomes are very, very good. So essentially pregnancy rates in and around 17, 18% in these patients. So what do we do? And this particular study, so I'll give you the latest study. It has come out just last month on IVF outcome in women with endometrial tuberculosis. And a very nice study where they compared patients with endometrial effects of tuberculosis along with the tubal effects of tuberculosis and compared with the controls. And the main focus is in every patient, pregnancy outcomes are poorer. But tubal tuberculosis patients, those who had only tube damage, did quite well and outcomes were very good. But those whose endometrium was affected by tuberculosis, the results were really dismal. So even patients with tuberculosis, classify them into endometrial or tubal tuberculosis, and you'll be able to give a better prognosis. I really believe that when the entire world says, give up, hope is what whispers, try it one more time. And we as specialists, as IVF consultants, have to give our patients hope. So what can we really do to give them hope? Anything which can help improve the problem areas, that is improving the ovarian reserve. So how do you improve the ovarian reserve? Most of the things I've talked about today are very practical. One is the injection of platelet-rich plasma, calcium gluconate activated PRP. 5 ml is injected into each ovary under transvaginal ultrasound control. This is being done. Many cases have been done in India as well by us also, and it is shown that it improves within 2 months the AMH, the follicle count, etc. And you can actually get eggs and embryos in patients who had no eggs to give earlier. What about ASCOT, that is autologous stem cell ovarian transplantation? And this actually has been found to give improvement in ovarian function in 80% of women. Many of them have gone on to conceive naturally. So stem cell injection into the ovaries definitely has a role to play in poor responder patients. This technique, of course, in vitro activation is a lot more complex, but very interesting to all of you laparoscopic surgeons, where you go in, patients in this particular study were completely menopausal. Their FSH was 35. They were already in amenorrhea for 4 months. In these patients, laparoscopy was done, ovarian biopsy or pieces were taken out. They were cut into segments and frozen. Whenever the time was ripe, they were taken out, cut into smaller pieces, because this actually disrupts the hippo signaling pathway leading to promotion of follicle growth. And they were put into AKT stimulators for 2 days, washed, and then re-implanted back under the tube. And believe me, the eggs started to grow in these absolutely almost dead ovaries, and 3 pregnancies were achieved in 6 patients. So pretty radical, amazing treatment and fantastic results. Some headlines, because this particular subject has been grabbing headlines. Scientists grow eggs in a lab from the earliest stages in ovarian tissue all the way to full maturity. This was in the London newspapers a while ago. Artificial ovary may help some cancer patients. This was in USA Today, again making headlines 2 years ago. And you can actually create an artificial scaffolding in which the eggs can begin to grow. So these kind of studies often done in cancer patients. But in India, tuberculosis is one of the biggest problems, as bad as cancer. And we could actually use these developments for our patients with tuberculosis. These were all the advances with ovarian damage. What about endometrium? And all of us know that thin endometrium is a huge problem. And we've tried aspirin, vitamin E, sildenafil, all kinds of things have been tried for poor endometrium. But what has worked and what has really helped in many cases is infusion of granulocyte colony stimulating factor. It is now many studies, and they've told us that GCSF infusion into the uterine cavity may improve thickness, but more than that, implantation rates. Again, PRP has a role to play here, and PRP infusion again has shown to have significant benefits in improving pregnancy outcomes in these patients. You can do a combination of both, and this is called primer technique, whereby PRP 0.7 ml is infused inside and GCSF 0.5 ml is given subcutaneously. And couple of doses of this, and patients had significantly improved implantation rates and IVF outcome rates after embryo transfer. So again, a very radical therapy, and you can see all of these are new studies, just maximum 2018, 2019. This particular study, mesenchymal stem cells were actually inoculated subendometrially, and the endometrium grew thicker, menstruation improved, and pregnancy outcomes improved. So all these therapies, very new, but showing huge promise. All of us know tuberculosis is a very bad disease, and everything may fail, and eventually you may have to resort to surrogacy. So bad patients, completely atrophic, massive adhesions, cannot be treated with hysteroscopy, MDR genital tuberculosis, you may have to resort to surrogacy. So I hope surrogacy is available in India, because we have a huge load of these patients with tuberculosis, damaged uterus completely. We have to always keep adoption at the back of our mind, because some of these dismal patients, we may still have to offer them adoption as the only possible solution. We are focusing on female genital tuberculosis, but just a mention of the male factor. Remember that when tuberculosis affects the male genitalia, the picture is that of ejaculatory duct obstruction. quantity as well as quality keeps on going down of the seminal fluid and sperms. And eventually the only thing which might work is a testicular biopsy. Even epididymal aspiration does not work because epididymis may be blocked in many particular places. So when you do a TISA, you get sperms, you do a ICSI, you'll be able to help the a caution, a word of caution, that when you're doing all these dramatic treatments for your patients with tuberculosis, remember that some patients with all this activity may end up with miliary tuberculosis, worsening of their tuberculosis. Very rarely, ovarian abscess has been reported following IVF egg pickup, etc. And surprisingly, even today, congenital tuberculosis in the neonate may be there with very bad morbidity and mortality. So keep in mind all these possible complications which can happen. And the last few slides telling you that learning and innovation go hand in hand. The arrogance of success is to think that what you did yesterday will be sufficient for tomorrow. It will not be. Science is changing every single day. And the future about tuberculosis, learn to treat tuberculosis. One huge opportunity, and the World Health Organization has underlined this, is pick up latent tuberculosis by some good tests such as interferon gamma release assays. Maybe those will be helpful in early diagnosis. Treatment options with shorter, better treatment protocols using rifampicin rather than INH may be better. If we diagnose early, we treat early, we can prevent this massive irreversible damage that happens. This study came out last year, very interesting. They actually used fibroblast growth factor 2, basic fibroblast growth factor, which was basically used for ulcers and because it helped angiogenesis of the ulcers, particularly diabetic ulcers. And in this particular study, this basic fibroblast growth factor was administered around the endometrium by ultrasound every 4 weeks in 18 patients. And it was found that with this infusion, the blood volume, endometrial thickness, everything improved. Endometrium started to grow, and patients who never had achieved pregnancy managed to become pregnant. So this could well be a good, fabulous new therapeutic approach. Definitely lot of focus on the endometrial biome, hundreds of studies now on the bacterial communities which may have impact on the reproductive success, and probiotic treatments are becoming more and more important. Regenerative medicine, I've spoken about it a little bit, huge focus on endometrial regeneration in Asherman syndrome with autologous cell therapy with CD133 plus bone marrow derived stem cells. And of course, eventually there's a possibility of a bioengineered artificial uterus coming up, and there are already studies on that. We never thought uterine transplant will be here to stay. But last year, we found that already 45 detailed reports had come out into the print, and 9 live births had been reported in very good scientific journals. So huge number of uterine transplants happening in these absolutely bad cases where uterus is completely damaged due to tuberculosis. And my last slide, not only uterine transplant, ovarian transplant is also playing a huge role. The type of transplantation, either auto transplant or even allo transplant, where the patient receives tissue from a genetically different but HLA matched donor. And please note the figures. 70% of patients who went ovarian tissue transplant actually got their function back, and pregnancy was reported in 52% of these patients. So huge potential here in ovarian tissue transplant in these patients in whom the ovary is completely damaged because of tuberculosis. So let me end by saying that the more I live, the more I learn. And the more I learn, the more I realize, the less I know. This is a favorite slide of mine because I know that I keep reading, I keep studying, I keep learning, but there is a long, long way to go before we can actually master this science. So thank you all. Thank you very much. Thanks once again, Sunita, for this wonderful opportunity.